I think we've had a great start to the day, a great half of the day so far. Lots of interesting points of view, and it's nice to see that there's common themes emerging across all of our speakers today. So we're going to continue on, and I'm sure we're going to hear more great stuff in this afternoon. So first up, we've got Mr. Steve Gillingham. Sorry, you have to excuse my English accent. Steve Gillingham, President of the Pharmacists Association of Newfoundland and Labrador. Thank you.
Thank you, everyone. Well, thanks for having me here this afternoon. I'm pleased to be joined by our Executive Director of PANL, Glenda, as well as some work colleagues and academic colleagues from the School of Pharmacy. So thanks for coming out. So I'm very pleased to be here on behalf of the Pharmacists Association of Newfoundland and Labrador. Our association is the voice of pharmacists in the province. Essentially, we advocate and negotiate for the benefit of the profession, our members, as well as the patients we serve. Our membership includes 700 plus pharmacists, 180 students, and the majority of the pharmacies in the province. So you'll find our pharmacists pretty well all across the island in different areas, both community pharmacies, independent and chains. You'll find us in hospital pharmacies, in industry, such as drug representatives. You'll find us in clinical settings, such as cancer clinics, dialysis clinics, HIV clinics. You'll also find us in academia, such as the School of Pharmacy, and as well as government in the Department of Health and Community Services. Today, I won't spend a lot of time talking about the financial situation or the current state of our healthcare system. I think we're all aware of that. We've been graced with a lot of that this morning. I'm sure we will more later. But I will say we are in a time of innovation and collaboration, and it's vital to address the rising demands in our healthcare system. As we face older and sicker populations, as we've heard as well, rising costs, and extremely restricted financial resources. During our time today, I want to talk about our profession, the role of the pharmacist in healthcare, and a few examples of ideas for solutions that we feel that we can help in this crisis situation. Some of those we believe will be easy to implement. Others, not so easy, and will take a bit of time and cooperation from resources. The basic question for consideration, I guess, is how we can leverage the skills and expertise of pharmacists for more effective healthcare delivery. I began by saying Happy Pharmacist Awareness Month, which is what this is. So each March, Pharmacist Awareness Month, or PAM as we refer it to, it celebrates the contributions that pharmacists make to our healthcare system, but also helps build awareness on the healthcare services and advice that pharmacists are now delivering. The theme for this year's PAM is Think Pharmacist. I'll ask you now to watch a brief video. Okay, so that video was launched last week to coincide with the beginning of our Pharmacist Awareness Month. But I think the message is applicable throughout the year and especially today. We are asking you to think pharmacists as we examine together our possible solutions for better but also sustainable healthcare. Given we are talking about the economics of healthcare today, I'd like to share some information which will be captured in an upcoming report by the Conference Board of Canada entitled An Academic Footprint of the Community Pharmacy Sector in Newfoundland and Labrador. So Newfoundland and Labrador's community pharmacy sector is unique. It provides healthcare to residents in a retail setting. It contributes to the province's wealth in several ways. It improves health outcomes, it creates efficiencies in the broader healthcare system, and it also creates jobs. The direct economic footprint of the sector in Newfoundland and Labrador is the economic contribution made by the community pharmacists that provide health services directly to residents. This contribution is equivalent to the wages and salaries that are paid to employees who work to deliver the services, in addition to any profits or surpluses earned in the process of delivering those services. The Conference Board of Canada analysis shows that community pharmacy sectors make a significant direct contribution to the economy and generates significant spillover effects into other sectors. Given that service delivery in the pharmacy is very labor intensive and that most services are produced domestically, the ratio of the direct gross domestic profit contribution is relatively high compared to other sectors. These numbers that I'll share, they are considered draft until the report is released in the short term. So in direct impact, Newfoundland and Labrador's pharmacy sector directly employed an estimated 3,000 people in 2016. As large as the employment impacts are, it is important to note that the GDP impacts are even larger. On a GDP basis, the pharmacy sector is estimated to be about $137.6 million, representing about 6.9% of the provincial health sector. The reason why the pharmacy sector accounts for a larger share of Newfoundland and Labrador's health GDP than its employment is because GDP per employee in the pharmacy sector is higher than any other health and retail sectors. The pharmacy sector also generates about $111.5 million in labor income among Newfoundland and Labrador residents. So indirect effects and induced effects, further to the people that the pharmacy sector directly employs, it also generates additional effects in other areas of the economy. Indirect effects describes the sector's supply chain, highlighting the inputs necessary to conduct retail pharmacy activity. Meanwhile, induced effects measures the spillover effects from those employed in the pharmacy sector. The total economic footprint of the Newfoundland pharmacy sector, direct, indirect, and induced effects combined, is estimated at over $254 million in GDP and over 4,000 jobs. In addition, the pharmacy sector generated $25.2 million in fiscal benefits to all levels of government in 2016, with about 79% of that occurring in Newfoundland and Labrador. All right, so that's enough dry stuff. So we'll start, I guess, with a little history of pharmacy. I guess when you think of pharmacy today, this is not the image that comes to mind. This was actually a pharmacy dispensary in the 1900s, and it's located in the Pharmacy Museum today at the Apothecary Hall on Water Street. So we've come a long way since then. I guess these images are more of what comes to mind when you think about pharmacy today. The change that the profession has undergone in 100 years is incredible, but even more impressive is the rate of change that the province and the country as seen in the last 5 to 10 years alone. As was captured in the video that you just saw, the days of the pharmacist being the dispenser of the medications are now long gone. With change comes opportunity. With the scope of practice of our, while the scope of our practice has expanded greatly, the healthcare system has definitely not kept pace with using the new scope of practice for its benefit. We must leverage the full skill set of the pharmacists and services of the community pharmacies in primary care. The scope of practice for a professional includes the activities he or she is educated and authorized to do. Increased scope provides opportunities for healthcare savings by reducing costs associated with unnecessary visits to physician's office and emergency rooms, improved access to health services, improved quality of care, and improved health outcomes. So this is a look back to the scope of practice for a pharmacist in 2012. That was, as you can see, highlighted there in the blue. Newfoundland at that time, Newfoundland Labrador, we had very limited scope of practice that was granted to us at that time. Moving on to 2016, not only has the expanded practice expanded, but we are now authorized to provide more of these expanded scopes. Pharmacists and pharmacies are uniquely positioned on the front lines of our healthcare system. Pharmacies are located in communities in pretty well every region of our province, and often are the heart of our smaller rural areas. They are essentially mini healthcare centers built with no government dollars, but that provide vital health services. They are conveniently located and opened on evenings and weekends. As our video showed, patients have more interactions with their pharmacists than they do any other healthcare professional. I think the video showed 14 times a year on average. So as government grapples with rising healthcare costs and difficult decisions that may include, as we already heard today, reduction in healthcare infrastructure, it becomes even more important to ensure that the system is using pharmacists and pharmacies to our full capabilities. We need to better leverage the skill set of pharmacists and services of community pharmacies in primary care. So I'll now get into some possible solutions that I feel pharmacists can offer our government going forward. So I'm not sure if anybody recognizes this gentleman. I certainly didn't before I started doing this presentation. So this is Dr. Charles Everett Koop. He was an American pediatric surgeon, Vice Admiral, Public Health Service Commission Corp., and he was served as the 13th Surgeon General of the United States under President Ronald Reagan. Now, lesson for you today. So he made a very, I guess, simple, but somewhat very true statement back in his time, that statement is having a profound impact negatively on our healthcare system here as well as across the country. So basically, what Dr. Koop said was, drugs don't work in patients who don't take them. Very true. Very simple, but very true, right? Oh, sorry. So 50% of Canadians today do not take their medications as prescribed. Adherence is inversely proportional to the number of times a day a patient is also required to take their medications. 80% compliance with 1 a day. Increase that to 4 times a day. compliance is reduced down to 50%. And it's also compounded by other means, such as the number of medications that a patient is on. In addition to that, polypharmacy, which is the simultaneous use of multiple drugs by a single patient for one or more conditions, also contributes to non-adherence. So, throw it out to the audience of how many Canadians over the age of 65 do you think takes 5 or more medications a day? Anyway. 20%? 2 and 3. 67% takes over 5 medications a day. So what about 10 medications in our senior population? Anybody? 10%, almost. 1 in 4, 25%. So a senior citizen, 65 years of age and over, takes this bag of medication every day. So as the elderly are prone to multiple comorbidities, they are at higher risk of polypharmacy and therefore may present with higher risk of non-adherence to medications compared to the younger populations, obviously. The estimated annual cost of medication non-adherence to the Canadian health care system is $14 billion annually. We can safely say in Newfoundland Labrador that would equate to hundreds of millions in non-adherence. These costs include such things as additional physician visits, extra laboratory tests, additional drug therapy, hospital ER visits, and hospital admissions. So how do we change that, and how do we make our patients more compliant? It can involve a number of ideas, but I'm just going to touch on one here today of how we think that a simple procedure that we can do in any pharmacy in our province can have great benefits for our patients. And there's compliance packaging. So from our bag of 10, we can go to this. Very simply. Looking at the image here, you can see obviously why a patient, as we said earlier, would be overwhelmed and not adherent to their medications. So compliance packaging is the customized packaging of these medications, which improves adherence rates. The need for compliance packaging increases with the number and complexity of medical conditions. When patients take their medication as prescribed, as I said earlier, there are fewer hospitalizations, fewer doctor's visits, less illness, etc. It's not hard to see how something as simple as this could benefit us both financially and improve health outcomes. Compliance packaging could also help people stay in their homes longer, as has been a common topic here today. Higher levels of care may be required if the patient cannot manage their proper regimens. In addition to ensuring that patients are compliant with their medications, and in doing so, decrease the spend, we are also actively involved right now during our negotiation stage with government at looking at some de-prescribing initiatives, if appropriate, as an expanded scope of practice for pharmacists in the province as well. So I'll also speak here now on another cost-saving issue that that we are looking at as well. So in 2013, the Pharmacist Association presented to government this particular paper called the Pharmacist Option, which was basically a recommendation of expanded scope of practice. All the recommendations were acted upon by government in some way, shape, or form, but some were not fully funded, and in doing so, were not fully implemented. One service that pharmacists now have the authority to provide is minor ailment prescribing. but it is not publicly funded, and therefore, like I said earlier, it's not fully implemented. Pharmacists have been assessing and treating for minor ailments for many years, but were always restricted to using over-the-counter medications. Or, in some cases, if necessary, they were referred back to their family physician for treatment. Our new authority to prescribe for minor ailments simply puts regulations and standards in place and allows pharmacists prescribing for certain conditions with expanded treatments beyond over-the-counter products. As you can see here, the treatment scheme for minor ailments, the top row here would be basically of a patient presenting with a minor ailment, going to their family physician, getting assessed, if appropriate, issued a prescription, brought to the pharmacy, filled, dispensed to the patient, counseled, and the patient is on their way. The second level is basically a pharmacist, a minor ailment patient presenting to a pharmacist doing an assessment, if appropriate, issuing a prescription to be taken to another drugstore if necessary, or filled at the current store, and the patient is counseled and on their way. Studies have shown that minor ailments comprise up to 40% of GP doctor visits. Increased demands on family physicians could be alleviated if other qualified healthcare professionals took a responsibility for less complex issues with patients. Here's just a list of some of the minor ailments that we can prescribe for. Patients have quick access to health professionals and prompt treatment. This is a solution that all requires no change to the current regulations or standards of practice, but does require the support of government to implement more widely. Now I want to focus on a study that was done a little while ago in 2017, a groundbreaking study actually, on the management of hypertension. This study shows that long-term comprehensive pharmacist care, which includes patient education and prescribing for Newfoundland and Labrador residents with hypertension, not only improves health outcomes, but will save the money for the province's cash-strapped healthcare system. So, among the 114,000 residents in Newfoundland and Labrador currently living with hypertension, that's not well controlled, if 40% of those, so 45,000, were treated with full-scope pharmacist intervention, half of these if the full scope care were administered to even half of those, projected savings would be more than $335 million over a 30-year period. The study looked at whether long-term pharmacist care would decrease events of cardiovascular and kidney disease, what magnitude of difference in survival, the quality of life could be achieved, what the effect of direct medical costs would be, and how cost-effective the intervention could be. While there's been long evidence available of the health benefits of pharmacist care and hypertension management, there has been, until this study, a lack of research done on the economic value of this type of care, particularly in Canada. So when half of the patients with hypertension that is not well controlled are considered over a 30-year period with full-scope pharmacist care, the study showed that there'd be 2,851 fewer strokes, 5,645 fewer heart attacks, 1,630 fewer cases of angina, 1,494 fewer instances of heart failure, 39 fewer instances of kidney failure, an additional 20,000 years lived. So quite impressive study. With the large number of people living with hypertension in Newfoundland and Labrador, the burden on society is enormous, both in health and economic terms. Pharmacists are highly accessible healthcare providers and ideally positioned to address the gap in hypertension management. With the infrastructure for those services already in place, we need to ensure our pharmacists are able to make use of their full scope of skills, improving outcomes in patients, and as a result, creating savings for the public purse. This study illustrates the importance of a long-term vision for healthcare and health outcomes. A vision based on 12 months in a fiscal year or a 4-year political term will simply not bring the changes that our healthcare system needs. Another report I'd like to bring to your attention is one issued by the Conference Board of Canada in April 2017. The report, titled "The Value of Expanded Pharmacy Services in Canada," assesses the health and economic impact of 3 services that are currently delivered within a community pharmacy setting in some provinces and which have the potential to be implemented across Canada: smoking cessation, advanced medication review, and management for cardiovascular disease, and pneumococcal vaccine. Depending on patient uptake, cumulative savings in Canada could range from $2.5 billion and $25.7 billion. The largest economic benefits of expanding the selected community pharmacy services would result from scaling up advanced medication review and medication for cardiovascular disease, with cumulative savings valued between $1.9 billion to $19.3 billion in healthcare system efficiencies and increased labor productivity by 2035. One last thing that I want to present of something that we're working on with government in now as well to try to help improve outcomes for our patients is prescribing in collaborative practice. So we all share the goal of creating better and more efficient healthcare with improved outcomes. One of the ways can be improved in healthcare is through the authority of pharmacists to prescribe in the collaborative practice. Regulations for pharmacists to prescribe in those settings have been drafted for some time, and we look forward to seeing those approved very soon. By that I mean the ability of a pharmacist in a hospital setting to prescribe for medications for mouth sores due to cancer-induced problems, as well as medication for nausea due to cancer-induced treatment. So in summary, pharmacists can and want to play a bigger role in healthcare delivery. Leveraging the skills and expertise of all health professionals is vital for meaningful change. To create a healthcare system that is responsive, efficient, and effective in improving the health of the people of Newfoundland and Labrador requires vision, innovation, and a willingness to do things differently. I'll finish with this quote. Innovation comes about through combining desperate ideas and disciplines in ways that seem weird at first. Get comfortable with the weird if you want real innovation to emerge. Thank you.
Thank you, Mr. Gillingham. We're going to take some questions now. I've got 2 right in the middle and 1 back here. And I'll get the rest after. So right here, Barbara. Yeah, and we'll get you after.
Is this on? Yep. I'm just going to read off a stat that you gave in your presentation. I hope I wrote it down right. That 25% of the 65 plus population take more than 10 meds a day,
Right.
or they have 10 medications.
10 plus, yes.
So just staying on a theme of unnecessary care and reducing costs, I'm just wondering if you know the stat of whether all those medications are actually necessary for that population, and whether you have any sort of solutions to perhaps reduce that kind of polypharmacy within patients.
Well, I don't have any specific stats if they're necessary or not. I don't know if anybody else. I might be able to refer you in a second to Debbie. But as I said earlier, we are working with government right now on a de-prescribing initiative, whereby hopefully we can, as pharmacists, be paid to provide that service to our patients, and hopefully, if necessary, remove any of these medications that are either not necessary or contraindicated, and hopefully provide better health outcomes to our patients. So, Debbie, I don't know if you got any numbers of.
Thanks. Debbie Kelly, I'm an associate professor here in the School of Pharmacy and director of the Medication Therapy Services Clinic. So we've been working to look at improving appropriateness of care, and I think that's really what your question is getting at, and I completely agree. In terms of statistics, looking at CIHI data, the Center for Institutes for Health Improvement, of seniors, so greater than 65 years of age or older, we're looking at 29% of seniors taking proton pump inhibitors, so stomach medications, potentially inappropriately. Our use of opioids in seniors is 6%, and our use of benzodiazepines is 21% in seniors. So of those three medication classes, for benzodiazepines, we have the second highest use amongst all Canadians in our seniors here in this province. And amongst the PPIs and the opioid medications, we are the leaders across Canada in terms of the number of seniors on those medications. So it does absolutely raise the question about appropriateness of care. And I think Steve presented a number of ways that pharmacists can contribute to improving health outcomes through improving adherence to prescribed therapies, chronic disease management in the case of hypertension. I would argue that there are even more opportunities. If we're actually going to look for really creative solutions and think outside the box and think about impact, it's got to come back not just to using what we have out there to minimize wastage, but really, are we achieving optimal patient health outcomes? That was raised a couple of times today. And I think these health system models whereby incentives are given based on optimal patient outcomes are really where we should be striving to go. And there are models looking at other ways that pharmacists can contribute to that. Debbie Ford presented on her model of primary health care, which I completely agree with those four healthcare providers, the physician, the nurse practitioner, the RN, and the social worker. But I would argue that pharmacists belong there as well. We belong at the point of prescribing decisions. It's extremely difficult and much less effective to try to discontinue medications after they've already been started. But being a partner in making those decisions around optimal medication use is one way that's been shown again and again, not to just reduce drug costs, but to actually have a very tangible impact on patient outcomes. So taking somebody off a sleeping pill, sleeping pills don't cost a lot of money, but the falls that happen as a result of them, the consequence of a hip fracture, landing in the emergency department, hospitalization, then not being able to return home, but having to go into a long-term care facility. Those are all opportunities that I think by looking at ways that we can optimize prescribing, that's really where the opportunity lies, I think, for integrating pharmacists into the system more holistically. So that was more than just an answer to the stats, but I figured I had the microphone. I was dying to say it all morning.
Thank you, Debbie. I appreciate that.
Okay, we got another question there in the middle in the back, then the next one's over here on the back.
Am I next? Or?
Yes, you're next.
Is this on? Yeah.
Yes, sir.
To be honest, I found your presentation insightful, but I found it troubling. And the reason I found it troubling was because there was such a focus on the economy and kind of as economic centered and talking about economic development and so on and so forth. And given some of the research that Pat Parfrey and others have produced in terms of the negative outcomes associated with drugs. And I'm going back and forth to the United States in this opioid crisis, which of course is creating all kinds of challenges because of the policy failures associated with that. So I understand, recognize the question or issue of scope of practice and some of the advantages in terms of thinking about scope of practice. But I have concerns unless those real critical policy failures or issues are addressed, because again, building a knowledge economy, whether it's in Boston or elsewhere, creates economic development or patterns of economic development. But we also need to understand the negative outcomes, the risks which are associated with a pattern of prescription, a pattern of addressing or dealing with health issues, which has not necessarily served the public interest. So I think that needs to be addressed.
I agree. I guess from our perspective, we wanted to show how we do contribute, but also at the same time, we want to get away from the actual core dispensing and move towards a more expanded scope role where we can actually provide our services, and the deprescribing was one incident of where we can make that happen. So
Our
I
next
know if go ahead.
Are you ready for your next question? Yep. Okay.
Goody? Can you hear me? I work with people who use drugs, and we're at the bottom of everybody's list. So if I go into a pharmacy to buy needles and I'm refused, where do I go?
Well, personally, from my perspective, you should never be refused at a pharmacy.
How can we ensure that people are not refused at the pharmacy when they go in and request to buy equipment, like needles, that will prevent disease, and they're told to go away? Because we have put a moral judgment on this. You are not getting this healthcare implement because I've decided it's not in your best interest. So I ask folks, what do you do?
Right.
Well, I go out behind the pharmacy and I find one on the ground and I use it. How can we enforce that the most vulnerable people in our society can spend their money in a pharmacy to get the healthcare supplies they need?
Right. Well, thank you for that. And like I say, from my personal. No. I understand that. It's something that we certainly have talked about before, both with not just from a needle perspective, but it's also increasing the pharmacy access to opioid-dependent treatments. And it's something that we are focusing on, and how can we increase the pharmacy's awareness of all these issues and hopefully get everybody on the same page where we support these people instead of not supporting.
There's a difference between treatment and prevention.
Duly noted. And like I say, it's something, it is something that we've talked about around our board table, and how we can get that to pharmacies, to make that to
Okay.
understand.
Okay. Thank you. We've got time for one last question. We've got one right here in the middle. Barbara?
Hi. A lot of your slides actually look like a lot of ours, the RNs, when it comes to scope of practice and that. But however, the past 10 years, med reconciliation has been a big thing in our healthcare settings. And when it came about, we as RNs talked about the increased workload that it had on us with, a decreased workforce on the ground level. And we looked to pharmacy. We said, boys, that's your ball game. Can ye do the reconciliation? So what I mean by that is a patient comes in, And we're trying to figure out, do they really know what medications they're on? Because half the time they don't. They just have the bottles and say, here they are, I don't know what they're for. They don't even, you say, do you have high blood pressure? No, mate, I don't have no high blood pressure. Well, you look and they're on 3 antihypertensives, right? So we looked to pharmacy to do this. Pharmacy, in turn, went to government and looked for upwards, I think, of 60 new pharmacy positions in order to do med reconciliation. Government said no. Guess who's doing it? No extra personnel, but the registered nurses are left doing it. I'm just wondering, so that would have cost, say, I don't know, I think it was 60 positions. So that would have cost a fair bit of money.
So this would have been done in the hospital setting before discharge?
No, on admission.
On admission, okay.
On
Sorry.
admission.
Yep.
So we got to have 2 liable resources now to figure out a person's medications. So a lot of times I have to go and get on the phone to pharmacy and get them to fax in a list of the current medications, along with looking at the bottles that the patient has. So I got to have 2 identifiers to say, yes, this is the current medications that they're taking. I know you talked about preventing falls and everything in long-term care. We have nurse practitioners now doing medication reviews in long-term care on patients, and the same thing that you're talking about. You know, they're decreasing the amount of falls and that because they're taking off the sedatives, they're taking off the anti-hallucinogens, they're taking off the sleeping medications. I mean, the amount of medication that these patients are on, and nobody is looking and doing a review on their medications. It's like they're put in long-term care and forgotten. Here's your list of meds, and if you're there 10 years, that's what you're going to be on, you know? So yeah, we do need that to be done. I'm just wondering, your plan didn't talk about what it's going to cost the system, what you're proposing.
In total, or just?
Well, what would it cost for you to, like, you're going to need extra personnel to be able to do what you're talking about. Because if you needed it for med reconciliation, I'm going to assume that you're going to need it for this.
Well, basically, so I guess what we're looking at is expanding our role to generate more revenue for us, but at the same time, removing these barriers from and giving people more accessible healthcare service. I'm not sure if Glenda wants to speak on anything there that.
Did you say increasing revenue for you?
No, it's increasing our revenue, but at the same time, it's allowing pharmacists to expand their role. So we're not so reliant on the core dispensing as we were before. But at the same time, we're increasing the availability of a pharmacist to do these expanded scopes.
Okay. I think we're just about out of time, so I'd like to thank you again, Mr. Gillingham, for a very good presentation.